Welcome to Ocular Graft-vs-Host disease. I'm Susan Resnick. I practice in New York City, where I concentrate on specialty contact lenses and anterior segment care. This course title has a bit of a double meaning, as it alludes to patients that survive cancer, but for whom we are involved in helping them survive the treatment. It also alludes to what we need to know and to survive clinically in managing this often devastating condition. This course will detail the pathophysiology, diagnosis, and ocular complications of chronic graft-versus-host disease. Specifically, we're going to review the immune response in graft-versus-host disease. We'll differentiate between acute and chronic forms. We'll highlight the risk factors and review current systemic treatment protocols. Most importantly, we're going to detail the ocular complications in chronic ocular graft-versus-host disease, and we'll try to formulate a diagnosis and treatment strategy for managing this condition. Of course, that's going to vary depending upon the individual patient, but it will give us an excellent overview. So what is graft-versus-host disease? Stem cell transplantation is a therapy commonly used for patients suffering from a range of malignant and non-malignant hematologic diseases. That would include anemia, leukemia, thrombocytopenia, autoimmune diseases, and some inherited metabolic disorders. Hematopoietic stem cells live in the bone marrow and churn out upwards of 7 billion cells every day. It replenishes our supply of red and white blood cells exhausted through wear and tear. Hematopoietic stem cells make either myeloid cells, for example, red blood cells that carry oxygen to the tissues, or lymphoid cells, which are the B and T cells that fight specific infections in the body. Currently, there are 3 different types of stem cell transplantation available. Autologous, which is giving blood to oneself. Allogenic is getting it from another individual, and syngeneic is getting it from an identical twin. In allogeneic hematopoietic stem cell transplantation, donor stem cells are harvested from either bone marrow, peripheral blood, or placental cord blood. The donors are human leukocyte antigen matched and may be related or unrelated to the recipient. Major histocompatibility complex compatibility is the most influential determinant of graft-versus-host disease. The major histocompatibility complex contains the genes that encode tissue antigens. In humans, it's located on the short region of chromosome 6, and it is called human leukocyte antigen region, or HLA. The incidence of graft-versus-host disease is directly proportional to the degree of HLA mismatching. Today, the majority of stem cell transplantation occurs with human HLA-matched unrelated donors. Therefore, we know that other genetic differences outside the HLA region or minor histocompatibility regions may contribute to graft-versus-host disease. Nearly 22,000 bone marrow or umbilical cord blood transplants were performed in the United States just about 2 years ago. The incidence of acute GVHD is approximately 30% in recipients of fully matched sibling donor grafts. It's approximately 50% in recipients of matched unrelated donor grafts. For chronic GVHD, we see approximately 30% in recipients of fully histocompatible transplants, and it goes up a little bit to 65% in recipients of mismatched hematopoietic cells or hematopoietic cells from an unrelated donor. We can break down the unwanted immune response in GVHD into 3 phases, and this is a diagram for which I'm going to describe the different phases. Phase 1 is activation of antigen-presenting cells. There is extensive preconditioning damage in the host, which releases the pro-inflammatory cytokines and major histocompatibility antigens. So in other words, when patients are going through bone marrow transplants or, they've been treated for cancer, we know that most of them have undergone significant amount of chemoradiation and therapy, chemotherapy and radiation, and this is what we mean by preconditioning damage. Conditioning regimens also damage the GI tract. This causes immune stimulatory microbial products such as lipopolysaccharides to be released into the systemic circulation, and this further increases host antigen-presenting cell activation. Phase 2 is the activation of the T cells. The initial site where T cells recognize alloantigens on both host and donor-type antigen-presenting cells is likely the secondary lymphoid organs in the GI tract. A second or co-stimulatory signal is also required, and that would be, for example, CD28 T cells and other antigen-presenting cells such as CD80 or CD86. The third phase is the effector phase, and this is a complex process. It involves both innate and adaptive immune responses, and it involves the synergistic interaction of cytokines and pro-inflammatory cells produced during the first two phases. The activated T cells migrate from secondary lymphoid organs to target tissues such as the skin, liver, GI tract, and it carries out cytotoxic activity. Cytotoxic T cells and natural killer cells are the major cellular effectors of acute graft-versus-host disease. Tumor necrosis factor is what causes significant destruction in the gastrointestinal tract. Because there is a connection between donor T cells and GVHD, one option to reduce the incidence of GVHD is to remove or deplete the donor T cells to prevent them from negatively affecting patients. There are two ways to do this. There's in vivo, where the T cell depletion consists of giving medications like anti-thymocyte to the recipient just before or just after transplant. In vivo T cell depletion is typically added to another immune suppressant regimen to reduce the risks for GVHD. The second way to do this is ex vivo, outside the body, where a machine is used to remove T cells from the stem cells before the stem cells are given to the patients. This procedure is more efficient in completing the removal of the T cells, allowing patients to avoid taking medications for GVHD prevention, and this is essentially a form of apheresis. A healthy first-degree relative may be used in a haploidentical match. When comparing haploidentical transplants using post-transplant cyclophosphamide to typical match transplants, the rate of chronic GVHD appears to be lower related to the use of the post-transplant cyclophosphamide. And we also know that as cytoxin. The donor type, which is whether it's matched unrelated or cord blood or half-matched, that ultimately leads to the best outcomes, is unclear and is still under active investigation. Immunosuppression with corticosteroids remains the mainstay of treatment in both acute and chronic GVHD, but a sustained response is seen in less than 50% of cases of acute and in 40 to 50% of cases of chronic. Although acute GVHD is a risk factor for the development of chronic GVHD, the treatment of acute does not decrease the incidence rate of chronic. So remember, they're going through HLA typing and they're trying to find the best match, and the definition of the haploidentical transplant is that it's a 50% match. And here is a list of some of the medications that are used to suppress the donor T cell functions. These drugs are given before and after the stem cell infusion. To standardize reporting, the 2005 and 2014 National Institutes of Health consensus development projects on criteria for clinical trials in chronic GVHD made recommendations for diagnostic criteria, severity scoring, and response assessments to be used in clinical trials. We do draw on many of these standards in everyday practice, so here's a brief review. Historically speaking, the first successful bone marrow transplant was performed in 1968. Chronic GVHD was first described in 1978 as a wasting syndrome observed in some long-term survivors of allogenic hematopoietic stem cell transplantation. Affected patients had severe sclerosis with joint contractures, lung involvement, weight loss, dry eyes, and other organ manifestations consistent with autoimmune disease. In 1981, Sullivan's group reported that treatment with corticosteroid-based therapy controlled symptoms and improved survival. So per the 2014 guidelines, diagnostic manifestations sufficient alone to establish a diagnosis of chronic GVHD may be found in the skin, mouth, GI tract, lung, and genitalia. So the 2005 NIH Consensus Development Project set the diagnosis and staging. They outlined the minimal criteria to diagnose chronic graft-versus-host. They gave us a scoring system for disease severity, and they abolished the 100-day dividing line and redefined acute and chronic as distinct clinical syndromes without a time restriction. And they gave us indications for topical and systemic treatment options. In 2013, there was a convention of the International Chronic Ocular Consensus Group, and they strongly recommended dry eye disease as a diagnostic clinical entity for chronic GVHD. And they proposed that the diagnostic criteria include the Ocular Surface Disease Index, Schirmer-1 testing, corneal fluorescein staining, and conjunctival injection. In 2014, the diagnosis of GVHD was based on signs and symptoms that are categorized as distinct, diagnostic, or other features, and we still use these guidelines now. Keep in mind that these guidelines are for conducting studies, but it's just important to understand that because it's such a complex disease, many times there were meetings regarding this, much like we see with the Tear Film and Ocular Surface Society, where we get the DUES 1 and DUES 2 reports. They said that there must be at least one diagnostic clinical sign or the presence of at least one distinctive manifestation confirmed by biopsy or other relevant test in the same or another organ. So in eyes, the scoring system is based on the presence of keratitis sicca, the effect on daily living, and the frequency of the use of drops. Schirmer testing was actually removed from the severity score due to poor correlation with symptom changes. Based on the NIH classification system, a diagnosis of ocular graft-versus-host disease isn't sufficient enough to be diagnostic for systemic chronic GVHD just taken in and of itself. So let's take a look now at just some specific distinctions between the acute and the chronic forms of the disease. So looking at the pathophysiology, in acute, you have direct donor T cell response toward the recipient cells, whereas in chronic, you have loss of regulation of central tolerance, causing indirect activation of the host T cells against itself. The tissues affected in acute include skin, bile duct, and GI. In chronic, we see it more in the skin, lungs, and mucous membranes. And then again, with the 2014 NIH consensus, we now look at the time frame a little differently. So on day 0, the graft is infused. At day 100 is where it can become overlapping, where the acute and the chronic can be a little bit more difficult to differentiate. But classic acute is certainly before day 100. Classic chronic is probably a little after day 100. And in, around the 100th day, you can get persistent late acute or recurrent late acute or even just de novo late acute. So, it becomes a little bit more difficult to classify just based on the time alone. But for the purposes of our discussion, we're going to use that 100-day mark to differentiate acute from chronic. And as we see in a few minutes, The eye signs for each are somewhat different. So, for the internists and the rheumatologists that do this, they have to pay more attention to this. This is just giving you some background information. So in acute, the risk factors for acute GVHD, we will have an HLA mismatch or unrelated donor. The patient will be older.